All right, everyone. Welcome to Lecture 18, where we officially enter what I like to call the metabolic powerhouse neighborhood of the body: the liver, the gallbladder, and the pancreas. These organs are biochemical overachievers. Seriously, if organs had personalities, the liver would be that friend who works 3 jobs, runs a marathon, meal preps, and somehow still has emotional energy for everyone else. From a histotechnology perspective, these tissues are also some of the most satisfying and sometimes frustrating specimens you'll encounter in the lab. Why? Because subtle structural changes often make big problems. A slightly swollen hepatocyte, that's a big deal. Fat droplets, an even bigger deal. Fibrosis, now we're talking long-term architectural remodeling. By the end of this lecture series, I want you thinking less like someone memorizing diseases and more like someone who can glance at a slide and say, something is very wrong with this liver. Let's get into it. I won't read these to you because we are not monsters, but let me frame what actually matters here. This lecture is about connecting structure to function to dysfunction to what you see on the slide. Not what the clinician sees, not what imaging sees, what you see when that paraffin ribbon hits the water bath. A few big anchors for today is number 1, hepatocytes are biochemical factories. When they fail, everything fails. Detoxification, protein synthesis, bilirubin metabolism, and even glucose regulation. The liver is basically the body's processing plant. Fun fact, you can lose about 70% of liver mass and it can regenerate. Try that with literally any other organ. No, don't. Number 2, gallstones. Tiny rocks, but huge drama. Histology loves obstruction stories. Blocked ducts results in pressure, which results in inflammation, which causes cellular injury. Very pattern-driven pathology. Your future pathologists will absolutely expect well-oriented sections here because duct relationships matter. Number 3, drug injury, one of the most common causes of acute liver failure. And here is where histotechs quietly save the day. Why? Because many drug reactions produce recognizable injury patterns. Zone-specific necrosis, steatosis, cholestasis. Once you learn the patterns, you can't unsee them. Number 4, cirrhosis equals architectural chaos. Normal liver is beautifully organized. Cirrhosis says, what if we replace this functional grid with scar tissue and confusion? Spoiler alert, the body hates that plan. Number 5, hepatitis. Know the differences. Not board-style memorization. Instead ask, what does inflammation do to tissue? So swelling, ballooning, necrosis, and fibrosis. Inflammation always leaves fingerprints. Your job is spotting them. Number 6, fatty liver disease, which is extremely common and increasingly seen in younger patients. Histologically, big, beautiful fat vacuoles pushing nuclei aside like they pay rent. They're hard to miss. Unless processing is bad, then everything looks like mush and we all cry a little inside. So again, histotechs matter. Before we talk disease, we ground ourselves in anatomy, because anatomy makes zero sense without knowing what normal looks like. Repeat after me. Normal first, always. Let's orient the players. The liver lives in the right upper quadrant and weighs about 3 pounds. Yes, your largest internal organ. It receives dual blood supply, which is clinically important and histologically interesting. So the portal vein has nutrient-rich and the hepatic artery is oxygen-rich. This creates gradients across the lobule, which explains why some injuries occur in very specific zones. We'll talk about that later. The gallbladder, small but dramatic, stores and concentrates bile like it's preparing for winter. When it contracts, bile shoots into the biliary tree to help digest fats. When it doesn't, stones, inflammation, pain, surgical consult, and then a specimen arrives, and then you meet it in the gross room. The pancreas is the overachiever of the group. It's both an exocrine, so it digests enzymes, and an endocrine, so insulin and glucagon. Two completely different functional personalities living in one organ. Histology hint you already know. Acinar tissue stains darker. Islets look paler. Once you see it, you always see it. It's like the histology version of that hidden image puzzle. Let's start big picture. When you open the abdominal cavity, whether in surgery or autopsy, the liver dominates your visual field. It is the largest solid organ in the body, and it sits like a protective shield over much of the upper abdomen. Just beneath it lives the gallbladder, quietly storing bile until it's needed. Posterior to the stomach sits the pancreas, the introvert of abdominal organs. Extremely important, but often overlooked until something goes very wrong. When a specimen arrives labeled pancreatic head mass, you should immediately think proximity to the bile duct, possible biliary obstruction, and potential jaundice. Gross anatomy gives context before you ever cut the block. Some worthless knowledge you may enjoy. The liver receives about 25% of cardiac output at any given time. It is basically the overachiever of perfusion. All right, now that we've officially entered liver territory, let's orient ourselves in the abdomen. The liver sits primarily in the upper right quadrant, tucked just under the diaphragm, and it's doing a lot more than just being there. Its location explains why liver disease often shows up with vague symptoms before anything obvious happens. From a gross and histology standpoint, this organ is large, vascular, and metabolically busy, which means it sees a ton of blood, it encounters everything absorbed from the GI tract, and it is constantly adapting at the cellular level. That constant exposure is why hepatocytes are so resilient, and also why they're so vulnerable when things go wrong. When you're looking at liver tissue later, remember, this organ was built to process everything, so subtle changes matter. This slide is all about traffic flow. The liver doesn't just make bile, it manages a whole duct system designed to move it efficiently. Here's the key takeaway. Right and left hepatic ducts drain bile from the liver. They form the common hepatic duct. That joins the cystic duct from the gallbladder, and together they become the common bile duct. A simple layout, but high-stakes consequences. Any obstruction here, stone, stricture, inflammation, tumor, backs bile up into the liver. And when bile backs up, hepatocytes don't love that. Caniculi dilate, and cholestasis develops. This is why bile plugs, ductal dilation, and portal inflammation tend to travel together. Analogy, think of bile ducts like storm drains. Clear flow equals no problem. One blockage equals neighborhood flooding. Let's talk external architecture. First up is the Glisson's capsule. This is the connective tissue shell around the liver. It's thin but tough, and it matters clinically because it contains pain receptors. So when the liver enlarges, it's not the hepatocytes screaming, it's the capsule being stretched. That's why liver pain is usually described as a dull pressure rather than sharp pain. Lobes, there's 4 total, so left, right, caudate, and quadrate. Gross anatomy loves lobes. Histology, not so much. Functionally, we care more about portal blood flow and segmental organization, but the lobes give us landmarks when orienting gross specimens. Ligaments, the falciform ligament separates right from left and contains the round ligament, a remnant of the fetal umbilical vein. Translation, you were important in utero, now you're just a landmark. This is one of those slides where gross anatomy and histology finally shake hands. The porta hepatis is the hilum of the liver, the main entry and exit point, and inside it lives the portal triad. So the portal vein, the hepatic artery, and the bile duct. Every time you see liver tissue on a slide, your eyes should automatically scan for portal areas. Why? Because portal triads tell us how blood is arriving, how bile is exiting, and whether inflammation or fibrosis is portal based. If portal triads aren't present in a biopsy, interpretation becomes very limited. No triads equals no context, and pathologists really like context. A helpful ID trick: the bile duct is the neat one, the artery has muscle, and the portal vein is big and relaxed, living its best low-pressure life. Now this is your reference point. A healthy liver should be smooth, uniform, reddish-brown, with sharp edges. This is your baseline your brain should always return to. Because once disease sets in, gross changes happen fast. Fatty change results in enlarged, yellow, and greasy. Cirrhosis is nodular, firm, and distorted. Congestion results in dark, swollen, and heavy. Gross pathology often whispers the diagnosis before histology confirms it. Architectural collapse at the microscopic level eventually shows up macroscopically. Fibrosis doesn't stay quiet forever. Analogy: the liver is like a warehouse with perfect aisle spacing. Fibrosis is just boxes piling up where forklifts used to move. Eventually, nothing flows. All right, let's start by zooming in on the gallbladder, which is far more interesting than most people give it credit for. Structurally, the gallbladder has three main regions: the fundus, body, and neck. The fundus is the rounded portion that peeks out slightly from under the liver. The body is the main storage chamber, and the neck tapers down into the cystic duct. Think of it as the funnel leading to the exit ramp. Now here's a histology pearl many people forget. The gallbladder has no submucosa. Instead, the mucosa sits directly on the muscular layer, which means when inflammation occurs, like in chronic cholecystitis, things escalate quickly because there isn't much structural buffering. You'll also notice two surface types: serosa, where it faces the peritoneal cavity, and adventitia, where it attaches directly to the liver. That posterior attachment is why gallbladder infections can irritate the liver bed. A fun but slightly gross fact: when surgeons remove a gallbladder, they're often dissecting it directly off hepatic tissue. It is not just dangling in space. From a histotech perspective, if you see liver tissue attached to a gallbladder specimen, it's totally normal. Do not panic. Now let's connect the anatomy to what you may actually see in the lab. On the diagram, you can follow bile flow. Right and left hepatic ducts, which go into the common hepatic duct, into the cystic duct, and into the gallbladder. Or when needed, gallbladder contracts and bile travels down the cystic duct into the common bile duct, then empties into the duodenum. Simple plumbing, until it isn't. Now look at the specimen image. Notice the difference between the smoother external surface and the more irregular one below. Pathology changes texture fast. Common things you may encounter: thickened walls, fibrosis, hemorrhage, adhesions. Chronic irritation makes the gallbladder tough, sometimes literally difficult to section. Worthless but memorable knowledge: gallstones form when bile becomes supersaturated, most commonly with cholesterol. Basically, bile tries to behave like rock candy. And succeeds. Histology tie-in: if the wall looks thick grossly, expect to see chronic inflammation infiltrates, Rokitansky-Aschoff sinuses, and possible dysplasia if long-standing. Always let the gross guide your microscopic suspicion. I also want to point out in this image that on the gross image on the right, that the top photo with the glistening capsule and the shiny surface and everything, that is going to be what we call the serosal surface on the gallbladder, right? So the shiny whatever. On the back, we see this roughened matte kind of, if you look real closely, you'd see cauterized artifact there. This is where they've had to separate from the liver, so this is going to be the adventitia side of the gallbladder, okay? All right, again, personality shift. We're moving from a storage organ to a biochemical powerhouse. The pancreas is divided into head, neck, body, and tail. The head sits comfortably in the curve of the duodenum, almost like it was designed to nest there, because it was. Embryology is efficient like that. Now let's talk ducts. There are typically two. The main pancreatic duct, which runs the length of the gland and joins the common bile duct at the hepatopancreatic ampulla. The accessory duct, it's not always present. Anatomy loves variation, but when it exists, it drains into the minor papilla. Clinical connection you should always keep in the back of your mind. Anything that obstructs this duct system backs up digestive enzymes. And when digestive enzymes activate inside the pancreas begins digesting itself. Not a design flaw, just a high-risk system. Most of this organ is exocrine acini, packed with zymogen granules. The endocrine islets, only about 1 to 2% of the tissue, yet they get all of the fame. Classic endocrine behavior. Take a good look at this image because orientation matters with pancreas specimens. The uncinate process is the hook-like extension wrapping around major vessels, particularly the superior mesenteric artery and vein. Surgeons care deeply about this area. So should you. Margins here can become critically important depending on the case. Notice how lobulated the pancreas appears grossly. That lobulation reflects connective tissue septa dividing clusters of acini. Another histology forward point, unlike the liver, the pancreas is fragile. Very little fibrous support, which means autolysis happens fast. If fixation is delayed, acinar cells can look ghost-like surprisingly quickly. Not bad processing, not bad cutting, just enzymatic reality. A fun analogy, the pancreas is basically a bag of enzymes waiting for permission. So handle accordingly. Now we arrive at one of the most clinically strategic intersections in the GI tract. The hepatopancreatic ampulla is where the common bile duct and main pancreatic duct merge before emptying into the duodenum. Think of it as a biochemical traffic circle. When flow is smooth, digestion hums along. When something blocks it, everything backs up. Classic example, a gallstone lodging at the ampulla. The result? Obstructed bile flow, which creates jaundice, obstructed pancreatic enzymes, which creates pancreatitis. One tiny stone, but major physiologic chaos. Histology correlation? Obstruction often leads to inflammation upstream. So if clinical history mentions obstruction, start anticipating tissue injury patterns before you even look down at the scope. Good histotechs don't just process tissue, they predict it. Let's finish this sequence by anchoring the anatomy spatially. Here you can see exactly where the ducts enter the duodenum. The major duodenal papilla is the main drainage site. The minor papilla is the accessory drainage, if present. And remember, anatomy loves variation. Some people rely heavily on that accessory duct, others barely have one. Clinical pearl, swelling at the papilla can obstruct pancreatic flow even without a stone. Inflammation alone can create a bottleneck. From a systems perspective, this is elegant design. Liver produces the bile, gallbladder stores and concentrates it, the pancreas provides enzymes, all precisely where digestion kicks into high gear. Coordination at its finest. Some worthless but fun knowledge, the sphincter regulating this flow, the sphincter of Oddi, sounds like a law firm but behaves like a highly trained gatekeeper. When it spasms, patients feel it strongly. All right, before we go deeper into the pancreas, we need to talk about the plumbing system that connects the liver, gallbladder, and the pancreas. Because honestly, if bile can't flow, everything downstream gets cranky. The biliary system is essentially a branching duct network that transports bile from the liver to the small intestine, where it helps emulsify fats. Think of bile like dish soap. Fat and water do not mix. Bile makes fat digestible. Now let's walk the pathway. The left and right hepatic ducts drain bile from the liver. These merge to form the common hepatic duct. The cystic duct connects the gallbladder, your bile storage tank. Together, they form the common bile duct, which eventually joins the pancreatic duct. And this is where things get clinically interesting, because when a gallstone blocks the common bile duct, you don't just get gallbladder problems. You can trigger acute pancreatitis. Histotech tip: when grossing biliary specimens, always be aware of obstruction. Dilation upstream is often your first clue. Again, pathology loves pressure gradients. Let this image orient you spatially. One thing I always tell students, anatomy is not memorization, it is visualization. Notice how packed together these structures are. The head of the pancreas literally hugs the duodenum, while the bile duct travels right through the neighborhood. This explains why pancreatic tumors often present with obstructive jaundice, dark urine, and pale stools. Not because the liver is failing, but because bile physically cannot exit. Clinical pearl: a painless jaundice patient is pancreatic cancer until proven otherwise. Burn that into your diagnostic brain. Histology correlation: chronic obstruction leads to bile stasis, inflammation, fibrosis, and eventual cirrhosis, all from a blocked tube. Never underestimate a duct. All right, now we officially shift gears into the pancreas. And I say this with love. The pancreas is dramatic. It does not do subtle. When it gets inflamed, patients know. When it develops cancer, outcomes are often poor. And when enzymes activate too early, it literally digests itself. Yes, autodigestion, nightmare fuel. But from a histotechnology standpoint, this organ is fascinating because it contains two completely different gland systems in one structure, endocrine and exocrine. Same organ, totally different jobs. Nature loves efficiency. The pancreas is a gland, but calling it a gland is like calling the internet a communication tool. Technically true, wildly underselling it. The endocrine function portion of the pancreas, the islets, release hormone like insulin and glucagon. These regulate blood sugar and metabolism. So when there's damage here, it results in diabetes. The exocrine function, the acinar cells produce digestive enzymes. The big two you must know: amylase, which breaks starch into sugars, and lipase, which breaks fats into fatty acids and glycerol. Quick memory trick: amylase equals absorbs carbs, lipase equals liquefies lipids. Your brain loves patterns, so use them. Histology tie-in: acinar cells stain beautifully because they are protein factories, tons of rough ER. Translation: they look basophilic and busy, just how we like our glands. Here is where anatomy meets clinical chemistry. Amylase and lipase can both be measured in the blood. When elevated, assume pancreatic injury until proven otherwise. But here is a test question favorite. Lipase is more pancreas specific. Amylase can rise in other conditions like salivary gland injury. Lipase is the loyal one. Why do levels increase? Because damaged acinar cells leak enzymes into circulation. Remember, enzymes belong in ducts, not blood. When they escape, something broke. These labs help clinicians diagnose acute pancreatitis, monitor recovery, and differentiate abdominal pain causes. A histotech perspective: acute pancreatitis often shows fat necrosis, inflammation, hemorrhage, and in severe cases, chalky white calcium deposits from saponification. Yes, the pancreas turns fat into soap. I wish I were kidding. All right, now we shift from normal structure and function into what happens when things go sideways. Pancreatitis is simply inflammation of the pancreas, but don't let that simple definition fool you. This can become a very serious condition very quickly. It can present as acute with sudden onset, potentially reversible, or chronic, which is long-standing inflammation that leads to permanent damage. The key concept I want you to remember is this. The pancreas is normally protected from digesting itself. It produces digestive enzymes in inactive forms, and safeguards exist to prevent premature activation. But when injury disrupts that protective mechanism, the pancreas essentially begins to autodigest. Yes, the organ designed to digest food starts digesting itself. Not ideal. From a histotechnology perspective, this means you may see inflammatory infiltration, fat necrosis, tissue destruction, hemorrhage, and in chronic cases, fibrosis. Some worthless knowledge that is not actually worthless. Pancreatitis is one of the few diseases where the pathology is literally caused by enzymes doing their normal job, just in the wrong location. So location matters. It matters a lot. So what causes this protective system to fail? There are several possibilities, but let's walk through them. Toxic, so especially alcohol. Alcohol increases enzyme secretion while simultaneously promoting ductal obstruction. That combination creates pressure inside the pancreas, and pressure is never your friend in glandular organs. Then there's obstruction, most commonly from gallstones. A stone blocks the pancreatic duct. Enzymes can't exit and they activate internally. Think of it like shaking a soda can and never opening it. Eventually, something's going to give. Then there's inherited genetic defects that can alter enzyme regulation. And then infection is less common but still possible. Now your slide lists alcohol as the most common cause, and historically that was heavily emphasized in teaching. However, clinically today, gallstones and alcohol are the top two, with gallstones often slightly leading depending on population. Not correcting the slide, just giving you some instructor level nuance. When you see acute pancreatitis, think gallstones and alcohol first. Patients with acute pancreatitis are usually very, very uncomfortable. The hallmark symptom, severe abdominal pain. Not mild, not annoying, we're talking constant, intense pain that often radiates to the back. Because remember where the pancreas sits, retroperitoneal. Patients frequently lean forward because it slightly relieves pressure. You'll also see weight loss, nausea and vomiting. And let's talk treatment. And this always surprises students. The primary treatment is resting the pancreas. No oral intake. If food enters the GI tract, the pancreas gets stimulated, and we do not want that. So patients receive IV fluids, nutritional support, and electrolyte management. If untreated, this can progress to necrosis or pseudocyst formation. A quick teaching tip. A pseudocyst is called pseudo because it lacks a true epithelial lining. It's walled off by fibrous tissue. And yes, they can rupture, which is exactly as bad as it sounds. Let's bring our histotech eyes to this specimen. Take a moment and really look at it. What jumps out? You should notice dark areas from hemorrhage and chalky white areas from fat necrosis and the irregular texture from tissue destruction. This is classic for severe acute pancreatitis. Here's what's happening physiologically. Lipase escapes and breaks down surrounding fat, which then releases fatty acids and that combines with calcium and then forms soap-like deposits. This process is called saponification. Yes, literally soap formation inside the body. You will never forget that once you see it. Histology correlation you might expect, we'd see ghost adipocytes, basophilic calcium deposits, neutrophilic inflammation. From a lab perspective, these specimens can be fragile, greasy, and difficult to section cleanly. Fat-heavy tissues love to chatter, so blade sharpness matters. Now we're looking at a cut section, and this is an excellent example of why gross examination matters. Notice the variation in color and texture. Healthy pancreas should be relatively soft and lobulated. Here we see pale necrotic regions, areas of hemorrhage, possible enzymatic digestion. This is a pancreas that has been through a lot. When processing tissue like this, fixation becomes incredibly important. Autodigestion doesn't stop immediately after removal. Enzymes can continue degrading tissue. Translation: delay fixation and you risk losing diagnostic architecture. And remember, pancreas already has delicate acinar structures. Once destroyed, you don't get them back. Clinical tie-in: severe pancreatitis carries a high mortality rate, especially when necrosis becomes infected. So while we often teach this as a GI disorder, it is absolutely a systemic threat. All right, now we move from the dramatic medical emergency energy of acute pancreatitis into the slow burn. Chronic pancreatitis is prolonged inflammation that leads to irreversible destruction of pancreatic tissue. And that word, irreversible, matters. Unlike acute injury where tissue can recover, chronic inflammation replaces functional pancreas with fibrosis, calcifications, duct distortion, loss of acinar cells, and eventually loss of islets. Translation: both exocrine and endocrine function decline. Most cases follow repeated episodes of acute pancreatitis. Think of it like repeated micro-injuries. 1 insult, recoverable. 10 insults, permanent remodeling. Causes? The big one by far is long-term alcohol use. Alcohol promotes protein plug formation, duct obstruction, increased enzyme viscosity, and direct toxic injury. It basically turns pancreatic secretions into sludge. Not ideal plumbing. Other causes include chronic obstruction from tumors or stones, anything that keeps enzymes trapped inside the gland. And remember, this is a slow, progressive disease. Patients may not even realize what's happening until major function is gone. Histotech connection. On histology, you'll see dense fibrosis, atrophic acini, dilated ducts, chronic inflammatory infiltrate, and calcifications. The architecture starts looking tired, like a pancreas that has seen some things. Chronic pancreatitis dramatically increases the risk of pancreatic adenocarcinoma. Inflammation results in cellular turnover, which results in mutation risk. The pathology domino effect. I love this slide for teaching. Side-by-side pathology is one of the fastest ways to train your diagnostic brain. Let's walk through it. The left image is acute pancreatitis. Notice the swollen gland, hemorrhage, some patchy fat necrosis, and a soft appearance. This pancreas looks actively injured. Think chaotic, inflamed, and enzymatically digesting itself. Very on brand for acute disease. Now the right image is chronic pancreatitis. Completely different personality. Now we see a firm texture, pale fibrosis, irregular contour, and scarring. Instead of explosive injury, we get structural remodeling, almost cirrhosis-like, but pancreas addition. When grossing these specimens, chronic pancreatitis is much harder dissection due to fibrosis. Your blade will tell you immediately. Trust me, microtomes do have opinions. By the time a pancreas looks like the one on the right, patients often have malabsorption, steatorrhea, diabetes, because the gland has essentially burned out. Now let's talk tumors, but we'll start with the friendlier ones. Pseudocysts are technically not true neoplasms, but they absolutely behave like mass lesions. They typically arise after acute pancreatitis, trauma, or duct rupture. Here's what happens. The enzymes leak, tissue digests, fluid collects, and the body walls it off with fibrous tissue. But importantly, there is no epithelial lining, which is why we call them pseudocysts. Pathology naming is nothing if not literal. Many pseudocysts resolve on their own. Others can become infected, rupture, or compress nearby organs. Imagine a balloon full of digestive enzymes sitting next to your stomach. Not a very comforting thought. When sampled, expect fibrous wall, necrotic debris, enzyme-rich fluid. No epithelial cells equals diagnostic clue. Always ask yourself, where is the lining? If it's missing, think pseudocyst. Now we shift tone a bit because pancreatic cancer is one of the most lethal malignancies we encounter. Most cases are pancreatic ductal adenocarcinoma, and unfortunately, it is currently one of the leading causes of cancer death. Why? Because it is a master of staying hidden. Early tumors cause almost no symptoms. Patients often present only when jaundice appears, which usually means the tumor is obstructing the bile duct. By then, disease is often advanced. Most tumors arise in the head of the pancreas, and anatomically that is terrible real estate because the bile duct runs right through it, so even a relatively small tumor can block bile flow. Treatment? A Whipple is not a minor surgery. It removes pancreatic head, duodenum, and common bile duct, as well as the gallbladder and sometimes part of the stomach. Basically, controlled anatomical chaos. Yet it remains the best chance for survival when caught early. Histotech insight: Whipple specimens are orientation heavy. Margins matter, lots of them. You are not just processing tissue, you are staging cancer. No pressure. This diagram helps you visualize why pancreatic tumors cause such big physiologic problems. Look at how tightly packed this region is. Bile duct, pancreatic duct, duodenum, ampulla. It is a traffic intersection. Now imagine a tumor setting up roadblocks. Everything backs up. Why does jaundice happen? Well, blocked bile duct results in bilirubin accumulation, which results in yellow skin and sclera. Often the first visible sign something is wrong. Surgical reconstruction. After removing half the neighborhood, surgeons must reconnect the pancreas to the jejunum, bile duct to the intestine, and stomach to intestine. It is surgical plumbing at the highest level. It's honestly wildly impressive. Whipple specimens are some of the most educational cases you will ever see. If you get the chance to observe one grossed, do it. You will understand pancreatic anatomy forever. Okay, we touched a little bit on it, so let's talk about the biggest surgical specimen you'll ever see come through the histology lab. Again, that is the Whipple procedure, also called a pancreaticoduodenectomy. It's hard to say. This is not a quick surgical fix. It is a massive, highly complex operation typically performed to remove malignant tumors of the pancreatic head, though it can also be done for a distal bile duct cancer or ampullary tumor. What gets removed? Typically, the head of the pancreas, the duodenum, the gallbladder, the common bile duct, and sometimes parts of the stomach. So when this specimen arrives in pathology, it is an anatomical puzzle. A histotech tip: orientation is everything. Margins must be identified correctly because surgeons and oncologists are asking one major question: did we get it all? Expect multiple margins from the pancreatic neck margin, the bile duct margin, the duodenal margin, and the retroperitoneal margin, which is very important. If you embed blindly without understanding orientation, you can create major diagnostic problems. Some worthless but memorable knowledge: the Whipple has one of the highest surgical complication rates, but it is often the only curative option for pancreatic cancer. All right, shifting gears slightly but staying in the hepatobiliary neighborhood, say hello to the gallbladder, the small but mighty storage tank of the digestive system. Students often underestimate it because it's small, but pathologists definitely do not. Why? Because gallbladder disease is incredibly common, and you will see these specimens regularly. Think of the gallbladder as the liver's Tupperware container for bile. It stores it, concentrates it, then releases it when fat hits the small intestine. Simple job, but when things go wrong, they go very wrong. Let's break this down physiologically. The liver produces bile continuously, but we don't digest fats continuously, so the gallbladder steps in as a regulator. What does it do? It stores bile, concentrates bile by removing water, and then contracts when fatty food enters the duodenum. Hormone involved? Cholecystokinin, or CCK. Remember that one. When you eat mozzarella sticks or anything deep fried, CCK tells the gallbladder it's showtime. Now here's a clinical pearl. When bile becomes too concentrated, cholesterol can crystallize, and that leads directly to gallstones. Remember this sequence. It matters for pathology later. A histotech connection? The mucosa actively transports water out, so histologically you'll see tall columnar epithelium specialized for absorption. No muscularis mucosa, no submucosa, just mucosa, muscle, and serosa. Efficient, compact, and dangerous when inflamed. Again, take a good look at this diagram again because anatomy explains pathology. Follow the bile. It goes from the liver to the hepatic ducts, to the common hepatic duct, to the cystic duct, to the gallbladder, back to the common bile duct, and into the duodenum. Now notice something critical. The pancreatic duct joins the common bile duct at the hepatopancreatic ampulla. This creates a shared drainage pathway. So what happens if a gallstone blocks the bile duct near that junction? You don't just get biliary backup, you can trigger acute pancreatitis. This is why gallstones are one of the most common causes of acute pancreatitis. Anatomy equals destiny, always. Okay, take a good look at this specimen, because honestly, this is probably about as close to normal of a gallbladder as most of you will ever see in pathology. And that is not an exaggeration. Gallbladders are removed because something went wrong, so our baseline is already biased towards disease. First, what should a normal gallbladder look like grossly? You want to notice a few key features. The color is typically olive green to dark green from the bile staining. Not black, not gray, not patchy. The wall thickness is thin, usually less than 3 millimeters. No rigidity, no obvious fibrosis. The surface is usually smooth and glistening. No exudate, no shaggy adhesions, no obvious stones, so no mucosal ulcerations, no drama. Pathologists love specimens with no drama. Now, histotech brain on for a second. When you receive a gallbladder like this, resist the temptation to go on autopilot, because even normal-looking gallbladders still get sampled. Why? Because gross normal does not always equal microscopic normal. You can absolutely see early chronic cholecystitis, cholesterolosis, in Rokitansky's Aschoff sinuses, dysplasia, which is rare but important, all hiding in an otherwise boring specimen. And pathology is very good at humbling us that way. Many of these patients had biliary colic without structural damage yet, meaning the dysfunction was mechanical or transient, not long-standing enough to remodel the wall. Think of this as the gallbladder equivalent of, we removed it before things got ugly. Preventative pathology, if you will. Even when it looks normal, measure the wall, open longitudinally, inspect the mucosa carefully, and palpate for tiny stones hidden in the neck, and submit representative sections, typically of the neck, body, and fundus, because missing an early lesion is far worse than submitting one extra cassette. If you stay in this field long enough, you will develop what I call gross radar. Your brain starts quietly asking, why was this removed if it looks this good? And that question alone makes you a stronger histotechnologist. So never stop asking it. A fun but true statement, a normal gallbladder in surgical pathology is like spotting a unicorn. Rare, beautiful, and slightly suspicious. Let's shift gears slightly and talk about when the gallbladder stops behaving like the obedient storage pouch it's supposed to be. Gallbladder dysfunction most commonly shows up as cholecystitis, which simply means inflammation of the gallbladder. This can be acute, think sudden obstruction and pain, or chronic, where repeated irritation slowly damages the wall. Now here is the key question I always want my histotechnologists asking. What is driving the inflammation? About 90 to 95% of cases are caused by gallstones, also called choleliths. The formation of these stones is termed cholelithiasis, and yes, your patients can absolutely have stones and never know it. Many are incidental findings during imaging or surgery, but once a stone obstructs the cystic duct, now bile can't exit. Pressure increases, the wall becomes ischemic, inflammation follows, and suddenly that quiet little storage sac becomes a surgical emergency. Which brings us to the treatment you will see constantly in pathology, a cholecystectomy, surgical removal of the gallbladder. Fun clinical pearl, the gallbladder is one of the few organs we remove regularly with minimal long-term consequence because bile simply reroutes directly from the liver to the intestine. Your body is basically saying, fine, I'll bypass the storage tank. Not all gallstones are created equal, and knowing the difference actually helps you predict the underlying pathophysiology. There are two primary classes. The first one is cholesterol stones. These are the rock stars of Western pathology, making up roughly 75 to 80% of cases. They form when bile becomes supersaturated with cholesterol, meaning the liver is dumping more cholesterol than bile salts can keep dissolved. Think of it like adding too much sugar to iced tea. Eventually, crystals form, crystals aggregate, and stones develop. Classic risk profile you've probably heard: female, 40, fertile, and fat. Crude? Yes. Memorable? Also yes. But physiologically, estrogen increases cholesterol secretion into bile, which is why pregnancy and oral contraceptives raise the risk. The second type is pigmented stones. These are composed of bilirubin calcium salts. They're more common outside Western populations and often associated with chronic hemolysis, biliary infections, and parasites. Anything that increases bilirubin turnover. Now look at these risk factors and don't just memorize them. Ask yourself why. Gallbladder stasis is when the bile sits too long and crystals form. Rapid weight loss is cholesterol mobilization. Hormonal changes, we have altered bile composition. And we have genetics, so transport protein differences. Histotech Pearl, whenever you hear stasis, think precipitation, sludge, stones, because biology hates stagnant fluid. If you ever gross a gallbladder, and you will, you'll notice something immediately. Gallstones are wildly inconsistent. Different shapes, different sizes, different colors. Some look like polished pebbles, others look like gravel. And very rarely are they chemically pure. Most are hybrids, mixtures of cholesterol, bilirubin, calcium salts, and proteins layered over time, almost like tree rings. Each layer tells a story about biochemistry at that moment. When stones repeatedly irritate the mucosa, the gallbladder wall begins to thicken from chronic inflammation and fibrosis. And something you'll appreciate microscopically later: clinical pearl. Stone size does not predict danger. Tiny stones are actually more likely to escape into ducts and cause obstruction. Big stones tend to just sit there and annoy everyone. Small but mighty. Take a look at this specimen. This is a gallbladder absolutely packed with cholesterol stones. Notice their color: yellow to yellow-green. They are smooth, and they're often faceted from rubbing against one another, like geological formations inside the body. Bile becomes cholesterol-rich, the crystals nucleate, and the gallbladder hypomotility allows them to grow. It's not just chemistry, it's chemistry plus poor mechanical emptying. This is why fasting, TPN patients, and rapid weight loss increase risk. The gallbladder isn't contracting regularly. Histotech note, these specimens are fantastic for correlating growths with imaging because radiology may miss purely cholesterol stones since many are radiolucent, meaning they don't always show up on X-ray. Now compare that to pigmented stones, immediately darker, often black or deep brown. These form when excess bilirubin binds calcium. Two classic scenarios, chronic hemolytic anemia and biliary infection. Black stones is sterile bile and hemolysis, brown stones, infected bile ducts. Another clinical insight, pigmented stones tend to be smaller but more numerous, which increases the chance they migrate into ducts and trigger complications like obstructive jaundice, ascending cholangitis, pancreatitis. So yes, gallstones are one of the leading causes of acute pancreatitis. The biliary tree is very much a shared plumbing system. Block one section and everything upstream suffers. Big histotechnology takeaway from this set of slides, when you see a gallbladder in the lab, always think beyond the specimen. What altered the biochemistry? Was there stasis, infection, hemolysis, or hormonal influence? Because pathology is never random, it is always mechanistic. I want you to take a close look at this stone, especially the rings you can see on cross-section. If this reminds you of tree rings, that's not an accident. Those concentric rings represent distinct phases of stone growth over time. Gallstones don't usually form all at once. Instead, they grow intermittently, layer by layer, as the composition of bile changes. Each ring reflects a different chemical environment in the gallbladder at that moment. These layers can contain varying portions of cholesterol, calcium bilirubinate, calcium carbonate, or other inorganic salts. So what you're really looking at is a timeline of biliary chemistry. Periods of stasis, inflammation, infection, hemolysis, or altered bile concentration all leave their mark, literally. That's why many stones are mixed in composition, even if we broadly classify them as cholesterol or pigmented. This is a really nice reminder that pathology is dynamic. Just like layered fibrosis or zonal liver injury, stones record repeated injury and recovery cycles. And just to be clear, even though these stones have beautiful internal architecture, do not section them. Your microtome blade will never forgive you. In clinical pearl, layered stones like this often correlate with chronic processes rather than a single acute event, which aligns nicely with patients who have long-standing gallbladder dysfunction or repeated episodes of biliary colic. So yes, if you remember nothing else from this slide, gallstones tell a story, and the rings are the chapter. I want you to take a look at this image and try not to get hungry. Tell me these do not look like nerd gummy clusters. Honestly, once you see it, you can't unsee it. Now obviously, please don't confuse pathology specimens with snacks. That is a career-limiting decision. But the comparison actually helps with memory. These clustered stones form when multiple small calculi aggregate together within thick bile or sludge. Instead of one dominant stone, you get these irregular lobulated clusters. Mechanistically, this often reflects biliary stasis, supersaturated bile, or poor gallbladder emptying. Over time, they bump into each other, fuse, and grow, kind of like a pathological snowball effect. Why do we care as histotechnologists? Because gallbladders with tons of small stones are often associated with chronic irritation, mucosal injury, fibrosis, and increased wall thickness, which means you should already be thinking this is probably heading towards chronic cholecystitis. Also, multiple stones increase the chance that one will migrate and obstruct the cystic duct. And obstruction is where the real trouble starts. So yes, remember the nerd clusters. Now we're back to the classic cholesterol stones, the ones you will probably see most often in surgical pathology. Again, notice their appearance, yellow to tan, smooth, often faceted if crowded together. They're firm but waxy. These form when bile becomes saturated with cholesterol. Normally, bile salts keep cholesterol dissolved, but once that balance is disrupted, cholesterol precipitates out into crystals. Those crystals become nuclei, and nuclei become stones. It's very similar to how rock candy forms, slow crystallization over time. Some major risk factors you should absolutely know. The famous, as I've mentioned before, 4 F's that still show up on exams: female, 40, fertile, and fat. Not politically correct, but extremely testable. Add rapid weight loss and estrogen exposure to that list as well. When you gross a gallbladder packed with these, always evaluate the mucosa carefully. Why? Because chronic mechanical irritation from stones can lead to chronic inflammation, Rokitansky-Ashkoff sinus formation, wall thickening, and even dysplasia in rare cases. Never assume a gallbladder is routine. There is no such thing in pathology. Every specimen deserves your curiosity. If you remember nothing else from today, remember this slide because it is one of pathology's more charmingly named findings, the strawberry gallbladder. And honestly, once you see it, you can't unsee it. What you're looking at is cholesterolosis, which occurs when cholesterol esters deposit within macrophages in the lamina propria of the gallbladder mucosa. These lipid-laden macrophages create tiny yellow stipples against the red mucosal background, giving it that very strawberry-like appearance. Now, histologically, if you were to zoom in, you'd see foamy macrophages packed with lipid, relatively preserved epithelium, and minimal inflammation compared to true cholecystitis. So this is often more of an incidental finding rather than a destructive inflammatory process. A fun, borderline useful knowledge: despite how dramatic it looks grossly, cholesterolosis usually does not impair gallbladder function in a major way. It's more of a, hey, look what I found moment for pathology. Think of it like glitter. Once it shows up, it's everywhere, but not necessarily causing chaos. Also important for your histotech brains, lipid washes out during routine processing, so what you're actually seeing microscopically are those classic foamy spaces inside macrophages rather than intact cholesterol. Your tissue processing is basically dissolving the evidence, politely. Now we transition into something you will see far more often in surgical pathology: chronic cholecystitis. This is what happens when the gallbladder has been repeatedly irritated, usually by stones, over a long period of time. Think of it as the gallbladder equivalent of chronic workplace burnout. Repeated injury leads to repair, leads to fibrosis, leads to thickening. Typically see a thickened fibrotic wall, chronic inflammatory infiltrates, and sometimes those Rokitansky-Ashkoff sinuses, those outpouchings of mucosa into the wall. And almost always, multiple choleliths. Patients often report pain after fatty meals because the gallbladder contracts against an obstruction, which is about as comfortable as it sounds. From a histology perspective, this specimen is a great reminder that chronic inflammation favors fibrosis. Acute inflammation brings drama, chronic inflammation brings remodeling. Analogy time: if acute inflammation is a house fire, chronic inflammation is a slow renovation that never ends and somehow makes everything thicker and less functional. And now this is a gallbladder that has absolutely had enough. Look at the sheer number of stones here. It almost looks like someone poured boba pearls into the lumen. When you see this many stones, you should immediately be thinking about long-standing bile supersaturation and impaired gallbladder emptying. Remember, bile is a delicate chemical balance. When cholesterol concentration exceeds what bile salts can keep dissolved, crystals form. Crystals become stones. Stones become repeat offenders. Grossly, these round stones suggest cholesterol-based calculi, though composition always varies. Histologically, the surrounding gallbladder often shows chronic inflammation, fibrosis, and sometimes mucosal flattening from pressure. Some worthless but delightful knowledge: a gallbladder can contain dozens to hundreds of stones, and occasionally patients have minimal symptoms until one decides to block the cystic duct and choose violence. For the histotech, this is your reminder that more stones usually equals more wall changes, so submit representative sections wisely. Don't let the stones steal all the attention. The wall tells a story as well. Now these stones look very different, darker, irregular, almost jagged, and that appearance is your clue. These are pigment stones. Instead of being cholesterol heavy, they are primarily composed of calcium bilirubinate, often associated with conditions involving increased red cell breakdown or infection. So think chronic hemolysis, biliary infection, and cirrhosis. The color matters here. Pathology loves a good visual hint. Unlike the smoother cholesterol stones, pigment stones tend to look rough and angular, like tiny pieces of volcanic rock. Histology connection. You may see more inflammatory changes with these because infection frequently plays a role in their formation. Also, quick processing reminder, stones themselves don't get sectioned unless requested, but always inspect them. Their appearance can help correlate with the clinical picture. Fun analogy, if cholesterol stones are river rocks, pigment stones are asphalt chunks. Neither belongs in the gallbladder. Acute cholecystitis is exactly what it sounds like, sudden, painful, and clinically urgent. Most often it begins with obstruction of the cystic duct by a stone. Bile becomes trapped, pressure rises, and blood flow can become compromised. That ischemia accelerates tissue injury. Grossly, the gallbladder may appear enlarged and take on colors ranging from bright red to green to even black if necrosis develops. And yes, it may be filled with pus or hemorrhage. This is no longer the watch and wait gallbladder. This is the call surgery gallbladder. Gallbladder carcinoma is uncommon, but when it occurs, it is usually an adenocarcinoma. Gallstones are a recognized risk factor, likely due to the chronic inflammation we just discussed. However, only about 1 to 2% of patients with gallstones will ever develop cancer, so stones alone do not equal malignancy. It is seen about twice as often in women. One major concern is anatomy. The gallbladder sits directly against the liver with very little separating them. That proximity allows tumors to invade the liver early, often before symptoms prompt evaluation. Unfortunately, many of these cancers are discovered incidentally after cholecystectomy. Here you can see a classic gross example of gallbladder carcinoma. Instead of the smooth mucosal lining we expect, there is an irregular exophytic mass projecting into the lumen. Whenever you see focal wall thickening or a mass like this, alarms should go off. Tumors here tend to be infiltrative rather than neatly contained, which contributes to delayed detection and poorer prognosis. Histologically, you would typically see malignant glandular structures invading through the wall, often with desmoplastic stromal response. A take-home message, not every thickened gallbladder is inflammatory. Always respect asymmetry.